All right, good evening, ladies and gentlemen. A very, very warm welcome to this evening's inaugural lecture. It's always fantastic to stand here and see people from a broad spectrum of areas within the university and indeed people from outside the university. And that's one of the advantages of this series, and some of you have heard me say this very many times before, that in an era when many universities have actually given up on the idea of inaugural lectures, I think it is still one of the real highlights of Keele that we are able to have this series of lectures and actually celebrate the achievements of our professors, whether they be internally promoted or indeed externally appointed. So this evening we're here to listen to the inaugural lecture of Professor Helen O'Sullivan. Helen was born in Birmingham and brought up in the outskirts of Birmingham. Her dad was an Irish builder who came over to Birmingham in order to build the motorways. So probably Spaghetti Junction is all his fault, I guess. Her mum actually was one of the first women CID officers in Birmingham City Police. And unfortunately, I guess in those days, it was the case that when women got married and had children, then they would then give up work and dedicate themselves to their job. And that indeed was the case for Helen's mum. And she was the first in her family to go to university. And we've just been saying that that's an important message, I think, to get across, not only within this room, but more broadly. She did her BSc in molecular biology at the University of Liverpool, and then she stayed there to do her PhD and a postdoc, indeed, in bacterial genetics. She took up a lectureship in biological sciences at Liverpool Hope University, and it was at that point she actually became interested in education, and in particular how young people learn and how they think about ethical issues, and in her specific case at that stage, in relation to genetic screening and genetic engineering. And that actually led to, I think, a lot of the groundwork that we will hear about today, in that actually it was that interest in developing an understanding of how the students develop and learn some of those skills that are not necessarily directly related to their subject, alongside critical thinking and indeed ethical reasoning. During her time at Liverpool Hope, she worked on a number of important curriculum projects, in particular embedding the idea of graduateness into the curriculum, which is an exercise that I think Keele went through a few years ago. And then she became Dean of Sciences and Social Sciences. She moved back to Liverpool in 2006, and that was to lead one of the centres that were part of a national programme, the so-called Kettles, and hers was a centre for excellence in developing professionalism. As I say, there were 74 of those schemes, and they were an important part of the national education agenda in the noughties. That part of that agenda that tried to bring that level of innovation and professionalisation of teaching into universities in a way that at that stage it was considered not to be in place. And most of the work I think that she's going to talk about this evening is actually based on the work that was done in that Centre for Excellence in Teaching and Learning. She came to Keele just at the beginning of this year as PVC for Education, and that was after being made Professor of Medical Education in 2013 in Liverpool. So she was appointed here as PVC Education and indeed a Professor of Medical Education, and it's in that capacity that I'd like to welcome Helen to the stage to give her a lecture, Why Emotions Are Important in the Professional Practice of Medicine.
Thank you. Thanks, Trevor. I did seriously consider dancing onto the stage to ABBA this evening, but there was just a little voice in my head that told me that perhaps wasn't the greatest idea. So thanks for that introduction, Trevor. What do you think of when you hear the word doctor? For many people, for the generations after the birth of the NHS, a doctor was a towering pillar of society, somebody whose word was their, bond, whose word couldn't be questioned, who was invariably white, middle class, usually male. And for generations of people who could remember life before the NHS, the overwhelming feeling was of gratitude. And it was that gratitude that enabled doctors to be raised to their sort of status in society. For me, doctors were the glamorous and heroic members of the American drama here. But now we see doctors everywhere. Doctors are accessible representatives of the communities that they serve, and we see them all over the media. We're very familiar with doctors in all sorts of guises. What is a common thread through all these representations, though, is the high regard that public have for them. And countless surveys have been done on what people think of the most important or the most trustworthy of the professions. And it won't surprise you to know that doctors always come top of those lists. Even, through all the changes that we've had in society, doctors are amongst the most trusted people in society. However, there was a time about 15 years ago where this particular status was thought to be potentially under threat. There were a number of scandals and high-profile cases that started to take the shine off the image of doctors. Perhaps they were infallible after all. Perhaps the way they worked and their decisions should be questioned. And along with a general decline in that kind of deference to authority and the democratisation of medicine that came along with the internet, there was some feeling amongst the medical leadership at the time that maybe something needed to be done about this. Maybe we needed to look at those factors that made a doctor a professional and think about how we could develop those factors and those behaviours in medical training. So really the most influential piece of work for me at the time was a report by the Royal College of Physicians called Doctors in Society. And this was, as I say, this was set up as a commission to investigate what was going on with the profession, what was going on with medical professionalism, and how could it be addressed. And there were all sorts of lessons that were spelled out in this report for the profession, and importantly, for medical education. And, quite often people say to me, well, what is medical professionalism? What does it mean? And for me, the definition that the Royal College of Physicians came up with in this report is still the best definition of medical professionalism. And it is, they say, medical professionalism signifies a set of values, behaviours and relationships that underpin the trust that public has in doctors. And for me, that word trust was always particularly important. How can we introduce training and activities into the medical programmes that will help our medical students to be those trusted professionals when people are at their most vulnerable in times of their life? So, about this time, as Trevor said, HEFCE had set out a call to create a number of centres of excellence in teaching and learning, all the settles as they became known, and there were 74 of them. And HEFCE was the funding council at the time. It's only been gone about 4 months, hasn't it? And we already miss it, really. It's been replaced by the Office for Students. But at the time, HEFCE wanted to put some money into learning and teaching to redress, as they saw, the way that a lot of universities, especially the Russell Groups and the research intensives, had been prioritising research and prioritising the careers of research active academics over those that were focused on teaching, and they really wanted to do something about that. So sitting in Liverpool, the head of the medical school at the time, Annie Garden, put together a compelling case to have a settle based at Liverpool. And I I was Dean of Hope at the time, at Liverpool Hope, and we'd already set up a settle there, and I was really excited by the concept. And one evening I was sitting in my office, and I wanted to check that our HR department had put an advert up on jobs.ac.uk for a senior colleague that we were going to appoint. So I just put senior whatever in Liverpool into jobs.ac.uk, and up popped this job advert for the director of the settle at Liverpool, the director of Centre for Excellence in Developing Professionalism. As soon as I saw it, I knew it was a job for me. I wasn't even looking for a job at the time. And it was just, I knew already as soon as I saw it was going to be a sort of career-defining moment. You know, so much money, so much freedom, you know, such a different time really in higher education. I didn't, at the time, Liverpool Hope didn't have any healthcare education, let alone any medical education. So it was a bit of a leap for me. But I knew that the work that I'd been doing on developing those graduateness qualities would be applicable to that curriculum. And not long after I got there, in fact, 1 month after I got there, Annie Garden left to go and set up the medical school at Lancaster, and I was reporting directly into the dean, and he said to me, "I don't want to know what you get up to unless you're in danger of bringing the university into disrepute. Just get on with it." And so, as I say, it was one of those very rare moments where I had a lot of freedom and a lot of money. So our settle, we set up this settle, and it was really for a broad range of developmental activities, and we did a lot of applied research as well. But there was a broad range of things. So we're doing careers guidance. There was a lot of work on developing professionalism, on how you assess professionalism. A lot of work on personal and professional development. These things that were all, those of you that have been in higher education a long time will remember these things as being very fashionable at the time. But also then developing into things like digital professionalism and looking at leadership. And importantly, each settle had a remit that was given to it by HEFCE to address the status of teaching-focused academics. And this was a really important part of the work that we did at Liverpool. Liverpool was one of the first universities, certainly one of the first Russell Group universities, to introduce a teaching and scholarship pathway. And it was a really important part of helping to, redress that balance and bringing in paritative STEAM for those of us. I moved on to that contract, and those of us who were really committed to that sort of work. So, in terms of what we did, we did a range of things, but I think for me, one of the highlights really was a collaboration with Val Wass, who first was at Manchester and then at Kiel. Many of you will remember Val. And Kees van der Vleuten at Maastricht. And we did some of the fundamental work on defining professionalism and integrating professionalism. It was such a fortuitous thing that I met Val. It was very early in my time at Liverpool. She was based in Manchester at the time. In fact, her GP practice was in Rusholme. And after the third visit, where I got lost coming off the ring road coming out Manchester, that was my decision to purchase my first sat-nav. So I've got her to thank for that as well. And really, I just want to, at this point, just really acknowledge the role that those two people, Annie Garden and Val Wass, had on my career. And here was I, this upstart, with no medical background or training, coming into medical education. And the support and the generosity and the warmth of that support was really important to me. And in fact, Val sent me a message last night. She'd seen this up on the website. So, still an influence. Actually, the work we did was with Kees van der Vleuten's PhD student, and he used to fly in from Maastricht, and we used to meet in Liverpool Airport in a porter cabin, and do all our work, and then he'd fly off again. So he came to Liverpool several times before actually even seeing any of it. But anyway, so these two papers, I think, that I did with Val and Kees were, really helped to define medical professionalism at the time and set that. I mean, there were other highlights as well. I mean, some of the work that my colleagues did in that settle was instrumental in influencing Tomorrow's Doctors, which was the outcomes for medical practice, the 2009 version, which set out the outcomes as a doctor, as a scholar and scientist, doctor as a practitioner, and the doctor as a professional. We did some of the early work on digital professionalism, trying to understand how medical students were behaving online and, some of the pitfalls they were falling into. So we were able to provide guidance and teaching materials around that. And a number of methods of evaluating change in the curriculum. We were commissioned by Mersey Deanery to develop some objective forms of assessment for teamwork and leadership, and I'll come on to that in a minute. And we introduced feedback appraisals for all students and used previously validated tools for assessing critical thinking to show that those reflective activities were having a positive impact. Tonight, though, I want to just highlight two pieces of work from all of this. The first is part of a spin-off into leadership, and I mentioned that the Mersey Deanery commissioned us to develop some objective measures of leadership, and as part of that we did a little spin out which I'll explain to you, and then I'll spend the rest of the time talking about the work that we did on emotional intelligence and how that has developed since. So this is just a little side. I've always found this piece of work fascinating, so I thought I'd share it with you. At Liverpool and in a lot of training settings, we make use of what's known as a high-fidelity simulated patient. And these are really high-end, computerised. You can inject them with stuff. You can, their blood pressure falls and rises. They're absolutely fantastic. And they're used for lots of types of training, as you might imagine. The first time I went to see one at Liverpool, it started talking, and I thought, oh, it talks, and it's got a Scouse accent, that's amazing. And then I realised that it was actually one of the clinical technicians at the back with a microphone, so that was a bit disappointing. But apart from that, they are really, really lifelike. They're fantastic. So what we were doing, we were using the Sim Centre to develop these objective tests. So the 50 medical students would do a simulated scenario, and we'd be looking for particular forms of behaviour around leadership and teamwork and what have you. So while we were doing all of this, the junior doctor that I was working with at the time, he was an anaesthetist, and he'd been very interested in some of the work around airline pilots, and there's a lot of parallels, I suppose, between being an anaesthetist and being an airline pilot, because it's 99% routine and dull, but if something goes wrong, people die. So it's that sort of keeping your concentration when things are very routine. And there'd been some work on the Korean airline, the Korean Air Service, because they had a really poor safety record, and there was a speculation that it was because there was a lack of ability to challenge the authorities. So the co-pilot would see the pilot was doing something wrong, but they wouldn't be able to, have the ability to challenge, even if they could see that it was going to lead to a disaster. So what we did was we set up a scenario whereby the students would take part in a medical procedure, and we checked the scenario with medical students at the same stage to make sure that it would be something that they would really understand, so that the mistakes weren't because they didn't understand it. And we set it up so that halfway through the process, the senior clinician would make 2 deliberate mistakes. That obviously the other people were in on it. The students had consented to be part of a research project on leadership and teamwork, but they didn't know that this was going to happen. So the mistakes, I've put these down because I knew there'd be some doctors in the audience. I didn't want to embarrass myself by trying to explain what the 2 decisions were. So the 2 mistakes in the scenario, as I say, with students at that stage, they were obvious mistakes. So what we did was we made these 2 mistakes, and if the students didn't do anything about it, we prompted them. We sort of, one of the other clinicians would say, "Is that right? Is he doing it right? Is she doing it right?" And if it wasn't after 3 prompts, if they still didn't challenge the decision, then one of the other clinicians would say, no, actually, that's wrong. We shouldn't be doing that. So, we recorded the scenario, and then we asked the medical students to sit and watch the video and do a pseudo think aloud technique where they would talk about what they were seeing and what they were thinking and feeling at the time. So we were saying to, talk us through what you were doing at that point. So there were 18 medical students and 2 opportunities to challenge an erroneous decision. So there were 36 opportunities to challenge. 20 decisions were challenged straight away. 10 decisions were challenged after 1 or more prompts. 6 were never challenged. And in 15 out of the 16 cases, the students knew that the decision was wrong. So there were 3 decisions that couldn't be explained. The student just couldn't explain why they hadn't done it. But for the other 13, here they are. And as you see, it doesn't add up to 13 because some of the candidates provided more than one reason. But the main reason was this kind of assumed hierarchy. The anaesthetist, he was a senior anaesthetist, he arrived, and we just transferred over our responsibility. And then there was something around the fear of being wrong and the fear of embarrassment. So what that led to was us thinking about how can we support the students, how can we give them some tactics to challenge authority in a non-confrontational way. So this concept of appropriate assertiveness, that we did with the students, so that they would have some tactics, they would have some phraseology to sort of say to a senior consultant, oh, actually, well, we haven't been trained, we haven't been taught that way. Could you explain it to me again? Because, maybe I've been taught incorrectly. Giving them some tactics so that they could challenge that. So, why emotional intelligence? So, really, the bulk of the work that I'm going to focus on and the bulk of the work that I've done since the Settle has focused around emotional intelligence in medical students. And really, like many people, I suppose, I was really taken with Daniel Goleman's book in the late 90s about emotional intelligence. I read it when it first came out, and I wondered if there were links between emotional intelligence and resilience. As I say, I was dean at Liverpool Hope at the time, and we had a big cohort of trainee teachers at the time. And I remember talking to the Dean of Education about what makes a good teacher once, and she's saying, do you know what really makes a good teacher? It's resilience, and it's being able to control your own emotions and being able to manage your emotions and those of children in the class. And when I got hold of the original project proposal for the Settle, there was a little throwaway remark in there that said something like, we'll be interested in looking at the role of emotional intelligence in building resilience in medical students. And it was that really kind of piqued my interest. I spent a lot of time talking to psychologists at Liverpool. I suppose it's fair to say that at this time, emotional intelligence was considered quackery, really. And there's a really prominent group of clinical psychologists at Liverpool who've done a lot of work on patient-provider communication. And I remember going to a seminar once there and then saying to them, afterwards, would anybody be interested in collaborating on some work around emotional intelligence? And it was one of those sort of tumbleweed moments, and I was kind of like shepherded out and don't come back again. It's a bit like that. So I kind of got on with the rest of the work of the Settle, but there was something there about emotional intelligence, as I say, that wouldn't go away. And eventually I did find a PhD student who was interested. His background was in psychology. He'd done a degree in psychology, and he was really interested in looking at some of the sort of behavioural aspects around medical education. So I persuaded him to come and look at emotional intelligence. We used an early measure that had received some positive critical analysis in the literature. And we started by simply just measuring emotional intelligence in medical students. What we found, rather worryingly, was that we looked at medical students when they first came in and measured their emotional intelligence, and then at the end, and we found that it had dipped, which was a bit worrying for all sorts of reasons, but also because at the time, emotional intelligence was considered to be immutable. It was considered to be a trait that you had or you didn't have. And so the fact that it was going down was really worrying. So we wanted to see if we could change it, but at first, all I was interested in was seeing if we could put some stuff into the first year programme that would help the students to keep their emotional intelligence at the same level. So we wanted to see if we could design an intervention that would alter emotional intelligence in medical students. And at the time, surrounding myself with clinicians, we looked to do a randomised controlled trial. And it was a good opportunity at Liverpool at the time because year 3 was split up into 5 rotations, equal sizes, but that the students were randomly allocated to those rotations. So we managed to persuade the Director of Medical Studies to let us have one of those rotations and to do an intervention with them. We then asked for volunteers from the other groups to make a similar size group that we could use as control group. And Liverpool was capital culture at the time, and there was lots of exciting stuff going on. And we got an arts-based group who were really interested in developing humanities and artistic qualities in trainee doctors and junior doctors. And we got them to design a programme for our third year medical students that would support the creativity and the expressivity of their personalities. And we thought this might have some impact on their emotional intelligence. And it was a series of workshops. And perhaps the highlight was a special exhibition of the Turner Prize shortlist that year, of which Mark Wallinger was the winner that year. And yep, that was the work. We had this private showing, and that bear just followed us around the whole time. And that won the Turner Prize. So that was a particular highlight. So we measured the emotional intelligence before and after the intervention in the control group and in the test group. And we were able to demonstrate a statistically significant difference between the mean emotional intelligence, the EQI as it was with that measure, in the intervention group and the control group. I mean, a cautionary note is that there were very small numbers in the intervention group by this point. There was a lot of dropouts, and the group that we worked with, so the students were saying things like, well, is it in the exam? Do I have to do it? And they were getting this wonderful, culturally rich experience, but, students are students, sorry, students. And that was, that was the why so many of them dropped out. And actually, when we debriefed the group, the arts group, one of them said, they're very tribal. I thought it was quite funny. So what this was really was the first empirical evidence in healthcare setting that an intervention could alter and, in fact, improve emotional intelligence. So that was that piece of work. We then later went back, a few years later, we went back and did a systematic review of the emerging evidence around interventions to support an improvement in emotional intelligence. And we did find significant evidence of that. So I think it was well established at that point that interventions could improve emotional intelligence. So at this point I should probably pause and explain a little bit about what is meant by emotional intelligence. And after that first piece of work, so we did that first piece of work and we were very excited by the results, and then the people sort of went away and things died down again. And I started to look at other theories and models around emotional intelligence. And I was really attracted to the work of Meyer and Salovey in the States. And they had defined emotional intelligence as a type of social intelligence that involves the ability to monitor one's own and others' emotions, to discriminate amongst them, and to use this information to guide one's own thinking and actions. And the really important part of their theoretical model was that emotional intelligence was an ability-based thing. You know, before that, as I said before, people had speculated that emotional intelligence was a fixed trait, and that once you had it, you know, the amount you had was what you had, and that was it. So this ability-based model fitted in with the work that we'd done that showed that it could be improved, and this is much more attractive in an educational setting. If you can alter something, then there's a point in using it in education. And their model basically has 4 branches, so 4 types of emotional intelligence. The first one around perceiving emotions. So can you perceive emotions in others? Can you pick up subtle cues about emotion in when you're talking to people, or you know, can you read the signals about emotion? Using emotional intelligence to facilitate thought, so helping you to think about things in constructive and useful ways through using emotions. Understanding emotions, understanding the complex issues around emotions and differentiating between different types of emotions and how to respond to them. And then finally, emotional management. Can you manage your own emotions and, importantly, those of others? And that concept of being able to manage your emotions is a really important one. And they developed a measure of emotional intelligence, the MySIT measure, and we were able to we got in contact with Meyer and Solovoy in the States and asked them if we could use their tool, and they allowed us to use the tool, and they showed us how to, you know, analyse it and what have you. And really, this was the basis of the rest of the work that I'm going to talk about. So, at this point, I met a psychologist who was prepared to work with me, Ian Fletcher, who's now at Lancaster. And it was a really important time to meet Ian because he'd been doing a lot of work on attachment theory and its influence on communication effectiveness in medical students. And really, that work was really interesting. It was really good for psychological modelling, but not so good for medical education. And I did say to Jim before, you know, the psychologists in the room need to look away now. But attachment theory is essentially looking at how you interact with your primary caregiver. So when you're a baby, the first person that looks after you, that relationship builds a sense of attachment that can be problematic or not. And there are 4 different types. It's speculated to be 4 different types of attachment, only one of which is positive. The other 3 are more negative. And what Ian had shown is that your attachment style has a real influence on how you're able to communicate with patients. But for me, this was no real use in education because it's hardly ethical to get a group of medical students into a room and say, I'm really sorry, you know, you've got a problematic attachment style and it's because your mom abandoned you when you were little, you know, and it's probably going to mean that you can't communicate with patients, you know. So really not being able to have an intervention to help that is really problematic. But what Ian had got through this work was a really robust and valid mechanism for measuring communication in detail. And it was set up in Verona, and it's known as the VR codes. And it was just a really intense way of measuring, looking for the cues that students pick up from patients and how they respond. And there was a way of watching a video of that and coding it and coming up with a measure of their communication effectiveness. So I thought all this work that he'd done and the methodologies that he'd developed were really could be really important in helping to move on some of the understanding about emotional intelligence. So what did we do? Well, over 3 years, we measured emotional intelligence using the MySIT test, the attachment style and the effectiveness of communication. And this was in their 3rd year summative OSCEs. And for those of you that don't know what an OSCE is, it's an objective, structured clinical examination that's a common part of healthcare education. And so we looked at 3 cohorts of medical students through that. We also took the first of those cohorts and we followed them into their 4th year OSCE and also into their 5th year GP placement, where we got permission to video their interactions with their patients on the GP placement and to code those as well. So we had a whole range of measures of emotional intelligence, attachment and communication styles. So we had a lot of data that we could look at modelling what was going on. So what did we find? Well, as in Ian's earlier studies, we found that attachment style really influenced the effectiveness of communication, and that high levels of emotional intelligence were also correlated with effective communication. And we used multivariate analysis to really, see what was going on there. But what we found, which was really interesting, was that high levels of emotional intelligence mediated the effect of attachment style. So there was no correlation between attachment style and emotional intelligence, but students who exhibited what you might call problematic attachment styles, if they had high levels of emotional intelligence, that mediated it and gave them a high level of communication. So this was really important because if we can alter and therefore improve emotional intelligence through education interventions, we can improve that patient-provider communication, and we can give students a mechanism of developing those skills that is really going to be helpful for them as they go into practice. Significant for patient care because poor communication accounts for a majority of complaints to the GMC. Although I was looking at more recent data, and actually there's been a little bit of a drop in that over the last few years, and it's probably because medical schools have been given so much attention to communication skills and that role that plays. So if anybody's interested in that, I think those are the 4 most important papers in this. The middle 2 in medical education, they set out, the second one down sets out all those relationships and the correlations, and then the third one down really looks at how those interact with each other and the models that were involved there. And then that final one looks at the interaction in the GP placement. And what we did as a bit of a side thing was we used the opportunity to look at the about communication in OSCEs in 2 different settings and the GP setting, and we were able to show that that they were measuring the same thing. So that was a bit of reassurance about those of us that rely on OSCEs, that they were measuring something real in patient communication. So, more recently, Ian and I were looking more recently at effective affective and cognitive empathy, and a speculative model that looks at the interaction between cognitive and affective empathy. So what that means is that if you're showing empathy to somebody, there are 2 ways that that's happening. One is something that's going on as a thought process, and one that's going on as an emotional reaction. And we speculated that the important empathetic reaction for medical practitioners was the cognitive one, and that affective empathy, too much affective empathy can lead to burnout and over-involvement and what have you. And Ian's gone on to develop that work. I suppose what I've been most interested in recently, the last 3 or 4 years, is the concept of the dark triad. And dark triad came really most to prominence in the management and business literature. And you probably heard a few years ago there was a lot of stuff in the media about is my boss a psychopath, this sort of stuff. And the dark triad are subclinical levels of psychopathy, narcissism and Machiavellianism. And the work that we did, I did with the medical students, we left out, we tried doing psychopathy, and then it's like, oh no, we're going to find out that some of our students have got psychopathic tendencies. We can't really do this. And even though it is subclinical, that word is so emotive really that we did take that out. But So what the last piece of work that I've done showed support a link between emotional intelligence and narcissism and Machiavellism. I'm just writing this up with a medical student at the moment. And there's a really interesting thing here around potentially having too much emotional intelligence and what you can do with it. So we've got some medical students in a medical school, should we just say an unnamed medical school, who is showing quite high levels of Machiavellianism, and it's correlated with emotional intelligence. And you might be able to speculate that people with very high levels of emotional intelligence could kind of use that to their own advantage to manipulate people, because they can work out what people want, they can work out how to communicate effectively with people and what have you. So that's an interesting sideline that we're just starting to look at there. And I suppose for me, what I've found really interesting about this work as I've kind of stepped back a little bit from it is how we've gone back almost 20 years, really, and resilience is now coming to the forefront. And this recent piece of work in academic medicine that was published just last month now shows, has resilience as a professional competence. So in the sort of professional competence frameworks, resilience is now coming forward. And this study that I've referenced here, what they did was they looked at a mindfulness program to help resilience actually it was in interns in Holland, and showing how that had improved their resilience through various qualitative methods, through talking to the junior doctors and to finding out, how it had helped them. So I think really that brings it full circle to where I started thinking about the role of emotional intelligence and resilience and the impact that might have. And since I've been in this job, I've been thinking a lot about this work and what's been portrayed in the media as the kind of crisis in student mental health. And I suppose I've done a lot of thinking about whether any of this work is relevant to that current issue. And could we start thinking about some of this work and the role of mindfulness in building resilience as a possible intervention in building emotional intelligence, and the effect that this might have on resilience and well-being of our students. And there is a positive psychology movement in the university. Many of you will be aware of it. Anthony Selden has written a lot on this. And I think there's a lot that we can learn about our role as a university in promoting the resilience and well-being of our students and our staff. I want to really acknowledge the role of key people in all of this work. I mean, I've mentioned Ian Fletcher, who's now Senior Lecturer in Clinical Psychology at Lancaster. Val Wass, who was here at Keele and supported a lot of this work. Walter Van Moot was the PhD student working with Kees van der Vleuten, the one that flew into the Porter cabin in Liverpool and did the work on the defining professionalism. Peter Ledbetter was the original PhD student that had faith in the concept of emotional intelligence and did the original work. And then Gemma Cherry did all of that detailed work with the emotional intelligence and the VR coding. It was an enormous body of work that she did there. Michael Moneypenny was the anaesthetist who did the Don't Follow the Leader project. And I'd also really like to thank and acknowledge the students at Liverpool and the patients, real and simulated. And a final thought, I suppose, and a challenge. Is there any aspect of this work that we as a university, we as a Keele community can build on for the benefit of all of our students in developing their resilience and well-being? And I'll leave you with that thought. Thank you.